Let me just grab this up so it doesn't.
There's something wrong with this mic.
Is it working?
This one should work.
Okay. Can you hear me? Can you hear me? Okay, so we are starting with a very important topic of inflammation. What is inflammation? You have your PBL, right? Acute inflammation and also probably chronic inflammation is going on now. So what is inflammation? Anybody from the class? How will you define inflammation? Yes. Immune reaction. Okay.
In response to pathogens or damage.
Okay. Any good definition? Yes. Yeah, it's basically a body defense mechanism against injurious agent, right? One thing which is very important in process of inflammation that you should mention, that inflammatory process always and always occur in a vascularized tissue. For example, unicellular organism like amoeba, it does not have inflammation because they don't have any vessel. So for calling inflammation, you had to have a vessel. And then the whole process goes on changing in the vascular caliber and many things. So it's clear. So how will you define inflammation? Basically, as a doctor, we try to heal the we just try to assist, but the healing is done by Almighty God, right? As a doctor, we just try to assist. Okay. Should I come there or roam around? If you can hear my voice, I don't want to stand here like this. Okay. I will try to be a little louder so that you can all understand. Right? You can hear my voice? Up to the corner? Good. So this is very important picture. It shows everything. Injurious agent should not be only microbes, but it could be anything, right? Which injures your body. You can cut your skin. That is also injury. And if you cut your skin, again the process of inflammation will go on. Try to heal that process. Clear? Just see this picture. I especially brought one thing for you. Because pointer doesn't work here. This is your skin, for example. The microbes are actually attacking your skin, or you have burned your head. Either way, the whole cascade starts. We have some cells which is present beneath your skin, and that is macrophage, dendritic cell, mast, which are also known as antigen presenting cells. So they take the microbe, or they take this injurious agent and then they present. But while they take it, they have a propensity to secrete some of the chemical mediator, like they are secreting now. Chemical mediator, amine and cytokines, to start the process of inflammation. And they actually act on blood vessels. And this blood vessels, which normally the blood floats in a blood vessels. And what is the function of blood? To nourish the whole body, to provide oxygen, right? So normally what happens in the blood, it goes there anywhere in the body, then the fluid usually leave the blood vessel, goes out, nourish that particular area, and then it comes back in the veins and goes back to the heart. This is normally going on. But in inflammation, there is something else which is also going on there. So you need to have in inflammation, push these cells which are inside the blood vessel, which does not come out normally, to bring these cells out. So bringing these cells out, you need to have some changes in the endothelial cells, in the smooth muscle cells, the caliber of the vessels, so that easily the cells can go out. Now the cells are out. Now they had to reach to the particular area where this injurious agent is there. For example, bacteria. Now they are gone out. They had to reach to the particular bacteria. That is called chemotaxis, attractant, or magnet. Now this attractant or attraction is called chemotaxis. We will discuss chemotaxis in day after tomorrow lecture when we'll be discussing chemical mediators. So actually it is a bunch of everything which we have to do. Hopefully you are with me in the lecture, not looking at your own, but it looks like that he is so busy. So you must not be attentive and looking at my lecture. He is looking at James Bond picture. He is not even interested in looking at me. He is not hearing. Huh? He is touching his mustaches and he is busy in looking at. Now he is with us. Alhamdulillah. Now he is with us. So what is chemotaxis, gentlemen? Hello? Yes. What is chemotaxis? I have asked you all in my first day that just give me your name, I can add your name written. Do not have a secret. I never ever push anybody to come and attend my lecture. You just text me, doctor, this is my name, please add in my attendance. I will do that. But if you are here, I want you to be attentive and with me all the time. If you are not interested in it, let go. Just give me your name, that of Abrar. At the end, please put my name in your attendance. I will do that. Okay. these things disturb us a lot. We wanted to give each and everything to you, what we have. And it really hurts us when we see that you people are not even interested in taking those things. Still, I remember when I closed my eyes, the professor who taught me pathology, you are a blessed one, you have lectures in your mobile, you don't have those luxuries. You have to be so attentive to attend that lecture and put all of their lecture in our. And when we closed now, even my eyes, I still remember my professor. I want you to be at least. So this inflammatory process starts, the cells goes out, and then chemotaxis, the cells goes to the particular area, for example, here, they eat this microbes, and then they kills it, and when they kill it, the neutrophils usually they die after killing the bacteria. And then this macrophage, the function of the macrophage is to clear the things. It clears the whole thing, wipe off all the things, and within 1, 2, 3, maximum 4 days, the whole inflammation goes off when it is acute. Yes, for chronic inflammation, it takes days, weeks, to months. Right? So one thing is clear now that there are two types of inflammation. One is acute, and other one is okay. Now then, as we know, inflamed means fire. Yes. You are not able to hear me? Okay. Now, inflaming fire means something is burning there, right? And it's a dynamic response, as I said, of a vascularized tissue manifestation of the disease. It's not a disease, but it's a manifestation, and serve to bring defense and healing process together. And it classified into two main groups: acute and chronic. Right? Acute usually short-lived, chronic longer one. Again, it's a physiological response to the tissue and cellular injury. We know that already. Acute inflammation lasts for, it's a transient one, initial phase, transient series. It starts within minutes, goes up to 1, 2, 3, maximum 4 days, not more. And the main important cell in acute inflammation is neutrophil. For chronic inflammation, it either starts after the acute inflammation or de novo. You don't need any acute inflammation, but it starts directly as a chronic inflammation, usually of longer duration. And the cells are lymphocyte, plasma cells, and macrophages. Clear? So again, we say that it's a tissue reaction of the vascularized tissue, right? So definitely, if it's a vascularized tissue, we have changes in the microcirculation. As we said, normally the blood has been supplied by the vessels. So vessels are there, supplied by this one. Then there is formation of fluid exudate. Fluid is coming out. And also the cells are coming out, cellular exudate for inflammation. Normally what I said, that certain amount of fluid goes out and then come back in. But in inflammation, it's a little bit more. So causes of inflammation, we have microbial infections like bacteria, viruses, fungi. We have physical like extreme hot, extreme cold. That is also important. Trauma, irradiation. For example, while you are making tea, you can pour your hot water on your hand, and that will burn your hand and starts the inflammatory process. Chemicals like corrosive acid, alkalis that also cause inflammation. Then we have tissue injury like ischemia and hypoxia when you squeeze the blood vessel or you block it. So the whatever tissue after that blood vessel will be either ischemic injury or whatever going on. Yes.
All the physical agents of necrosis, etc.
You can even add because they are related to one another. Yeah. And then a foreign body blunt injury, you can have a injury of a stick, you can have injury of a bullet, knife, whatever, blunt injury or sharp injury, or immune reaction like hypersensitivity reactions. This is also causes inflammatory response. Clear? Now, cardinal signs. Anybody tell me about the cardinal signs? How many? Yes, five. Yes,
They were described by the plumbers 100 years ago.
very nice.
Right here,
Heat,
redness,
redness.
swelling,
Hmm.
and loss of function,
Okay,
and I forgot the
pain, right? So, redness, warm, pain, swelling, and finally, loss of function, right? Which actually the first four, as he said, ancient Romans, Celsius has discovered this in 20 AD, but the last one is recently 1870 by Virchow, right? And then finally, the Louis has given us a triple response in 1927, and he has said that we have flush, which is done by capillary dilation, flare, which is done by arteriolar dilation, and finally wheal, which is exudation and edema, which you see here. Okay, so this is actually been told us by the Louis. Then we have added, as my in you remember my first lecture, that we have some suffix in for inflammation. We have itis. So if it is appendix, we call appendicitis, colon, colitis, liver, hepatitis, joints, arthritis, bone, osteomyelitis, kidneys, nephritis. OMA is used for cancer or benign or malignant, whatever. So all OMAs are cancer or tumors? No, because granuloma is inflammatory process. Although it is inflammation, but we call it OMA, granuloma. It's not a tumor, right? We will be discussing this thing when we will be discussing chronic inflammation. So this is a picture which shows different things taking part. For example, in the blood vessel, we have neutrophil, lymphocyte, monocyte, eosinophil, basophil. These are the cells which are present inside. Then we have platelet and then proteins. Then we have endothelial cells, basement membrane, and then smooth muscle. Everything is taking part in inflammatory process. We have mast cells, fibroblasts, macrophages. We have already discussed dendritic cells. They are antigen presenting cells, which brings the thing. Then we have elastic collagen fibers, and protoglycan. All of them are actually taking part in inflammatory process. Now, this is a classical example of inflammation, acute appendicitis, and it is a medical emergency. If you have a patient of acute appendicitis, you have to shift that patient to operation to take that appendix out. Otherwise, what will happen? It will burst, it will rupture, and again, it is a medical emergency and catastrophe. Like for the example, this one. This is a very necrotizing appendicitis. If we leave this appendix like this, it will burst. Almost it will burst. While taking out this appendix, some of it is. It will burst in the peritoneum. So you will be having peritonitis, and peritonitis is a serious. Yeah, okay. Okay. So then we have acute inflammation. Definitely, today we will discuss acute inflammation. So you had to have full concentration how this acute inflammation is taking place. As I said, it's a rapid response within minutes. Within a minute, injury happens and inflammatory process starts. It could be, delivered by leukocyte and plasma proteins such as antibodies and a site of infection to tissue injury. You know that. So it has three major components. Number one, alteration of vascular caliber. Number one. Number two, structural changes in microvasculature. And number three, then immigration of the cells from the microvasculature into outside world, outside tissue. Normally, blood will our WBC never comes out until it is needed, and now it is needed here. So when the things are coming up, we have divided the thing in two main groups. One is exudate and the other one is transudate. Now, exudation is something else. Nothing doing with exudate and transudate. Remember, exudation means any cell or fluid is coming out from the vessel is called exudation. If you ask about exudation, means we are just asking about the fluid or cells are going. Now, specifically, if I ask about exudate, means the fluid is rich in high protein concentration, more than 3 grams per dl. It should contain cellular debris, means cells are also there. Plus, the specific gravity will be more than 1.020, right? Specific gravity more than 1.020, and definitely it applies increase is normal for perpetuity. It had to have some change in the vessel. On the other hand, if we talk about transudate, low protein, mostly albumin, less than 3 gram percent per dl. No cells are only few cells like lymphocytes, right? Here, large amount of cells. Here, few cells. Hardly you see. The specific gravity less than 1.010. Specific gravity very low. Usually, it's an ultrafiltrate. And how it happens, if you just go to this picture, it will be clear. If you talk about the normal blood picture going on, after this lecture, there is another lecture or your PBL? PBL. So I'm trying to finish it between that, but usually your PBL starts 15 minutes after this, right? I also used to take PBL, I know. So normally, if you talk about this vessel, normally because in the arteriolar end there is increase in hydrostatic pressure, so the fluid goes out. In the venular end, the fluid come back because of the colloidal osmotic pressure. Normally it goes like. Now what happens if there is congestive heart failure or there is venous obstruction? There is increase in the hydrostatic pressure. So more and more water is going out. Probably WBCs are not going out. Only water is going. Although probably we have a normal oncotic pressure. Now, just as an example, for example, normally here 1 ml is going out, and at the venular end 95% comes back. Only 5 to 10% remain outside, which is taken up by lymphatic. You all know. Here, what happened? Instead of 1 ml, because of the increased hydrostatic pressure, 2 ml is going out. Although we have a normal protein, what will happen then? 1 ml will come regularly as it comes. But what happened to the other 1 ml? It remains outside. So slowly and gradually that area becomes swollen. It is called edema. Okay. Or if suppose hydrostatic pressure is normal, there is a problem in colloidal osmotic pressure. How? Either protein are less formed by liver, or the kidney is not taking care. It has been excreted from the kidney. So the oncotic pressure will come down. So 1 ml of the blood is going out. Only half ml is going to come back because of the decrease oncotic pressure. What happens to the remaining half? Because only 0.5 or 10% taken up by the lymphatics, but remaining 40% is still outside. So slowly, gradually, what will happen? Slowly. You must have seen your elderly, probably patient, or even in the family members, they have swollen foot. This is because of the okay. And in inflammation, remember, this thing doesn't happen because you had to have changes in all of the things. You have changes in the vascular caliber, so there is dilation of the blood vessels. You have a gap between endothelial cell. Do you have gap here? No. You have a gap between this one. Not only fluid, but also cells are going out. So there should be some different phenomena going on here. Clear? Okay. Now as we were discussing acute inflammation, the acute inflammatory cell is neutrophil. It's a key cell. It is been produced in the bone marrow. It has a normally present in the blood. How much concentration? 60, 65. Okay, normally present. Short-lived in a vessel. It is 4 to 5 days, and when it comes out in the tissue, it remains for only hardly 1 to 2 days. Less, 1 to 2 days, not more. It will die. It has a propensity for phagocyte, means it eats up the microorganisms, plus it's capable of killing the bacteria. Okay, so this is another picture, again very nice one. So it has vasodilation. You see, it's a normal one. You see vasodilation? Yes. Hardly 1 or 2 cells are here, and here lot of cells, right? And the vessels are engorged, dilated one. So so you have vasodilation, you have exudation, means cells are coming out. Immigration. Now the cells which are coming out is going towards the injurious agent to take care of, and finally chemotaxis. You need attractant or magnet to pull those cells towards the injurious agent. Okay, so this is how it starts. For example, here is the blood. So it has a small caliber, and suddenly it increases. So there is only, remember, a local dilation of the vessel. For example, if you have your 4 brothers in a house, you have 4 bedrooms, and one of your brothers say that I need a good shower. So you bring a plumber and take a big bore pipe for your bathroom. And then when he starts, and the other brother has small narrow pipes, and one of your brother has big. What will happen? You will be having an excellent pressure. Now the other day, the other brother said, "Oh, I will do the same thing." So all the brothers will take a big bore pipes. What will happen? The pressure will go down. So if you have a local increase in the dilation, then you have increase in the pressure. And for example, in a body, when all of the blood vessels dilate, it is called shock, right? Because suddenly all of the vessels become dilated and the perfusion is hot, and the patient will fall down because it has not a propensity to supply the blood. So there is only local dilation, and by local dilation, the axial flow of the blood. Normally, what happens? The neutrophils and WBC travel in the center because they are bigger, then RBCs, then platelets, then proteins, fluid, right? But as the caliber of the vessel increase, what will happen? There is stasis and turbulence. When there is turbulence, then this axial flow will not remain like this. What will happen? RBCs, they join together and form rouleau formation. How you spell rouleau? ROULOUX, and you pronounce it as rouleau. Rouleau means a group of RBCs. So when they form a rouleau formation, they become bigger and they become in the center, and they pushes the WBC in the side. Clear? It will go towards the endothelial cells. The main program is to retain RBC inside and push the WBC out. Okay, so so it's a reaction of the blood vessels, change the vascular caliber, increase in the vascular permeability. You want to take the blood out, and then lymphatic vessels to change in the caliber. So when the inflammatory process starts, acute inflammation, there is transient vasoconstriction. So suddenly there is collapse of the vessels or arteriole there for just few seconds, 1 or 2 seconds, 3 seconds, 5 seconds, and suddenly there is vasodilation. And this vasodilation usually takes because of the nitric oxide and histamine. these chemical mediators dilate the blood vessels, right? So if you see here, it's a very important picture. This one normal. The patient does. It's not a patient. No microbes. So normally these capillaries are closed. So the channels are closed by these sphincters. You don't need excess amount of fluid. So these are the arteries. So arteries expel the fluid outside, and in veins they go back to the body. Normally it happens like that. But you need in inflammation larger amount of area. So these sphincters they open, and all of the capillary are being utilized. So more and more blood is coming there. So more and more will be cells going out of the body. Clear? Okay. Now permeability increase. Initially it is histamine and nitrous oxide for 15 to 30 minutes. Then these are the mediators. Finally, what happens? There are burn, exudation, and ultraviolet. They called delayed response. It takes few hours to 1 to 2 days, right? So if you see this picture, it will clear everything. Normally, if you see the WBCs are in the center, then RBCs and platelets, everything. So what happens as the axial flow changes, the neutrophil will come towards the endothelial cells. There is dilation and gap between it, and this gap is produced by mediators, and the mediators are nitric oxide and histamine, which appears there for 15 minutes to half an hour. And then there is also delayed response, which is done by the the burns or toxins, which actually damage the endothelial cells. Again, it helps in permeability. Then we have these neutrophils. These neutrophils, when they attach on the endothelial cell itself, they damage the endothelial cells, permeability stuff. And the last one is basically VEGF, which is transcytosis. It creates holes between in the endothelial cell, and it allowed fluid to go out. So these are the 4 or 5 processes. Response to lymphatics. What happens when the excessive fluid is going out? This lymphatic channel they become alert. Again, the lymphatic channels also become open, right? Because it was few, now you need more. So more channel will open, and it goes towards the lymph node. So if it is micro, what will it do? It will infect the lymphatic channel, which is called lymphangitis, and it goes towards the lymph node. And if it infect lymph node, that will call lymphadenitis, lymphangitis, and lymphadenitis, because the fluid contains micro. Finally, what happens? That this lymph node or lymph follicle, if you remember when you were small kid, during sore throat, you have tonsillitis, and your probably Baba have taken you to the doctor, and he used to examine your throat. He is not looking your tonsils. Yes, by saying he looks into your throat, it is red, and then he palpate here. Why it is palpating? To see the lymph nodes. The lymph nodes are swollen and painful, and then he gives you the treatment. Right? This is whole of the cascade. Okay, so now we have to see that how the cells are coming out from the vessel. So it has margination, rolling, and adhesion. First of all, the cells has to come down near the endothelial cells, then it will roll on the endothelial cell, and then it stick to the endothelial cell, and finally it goes out migration from the endothelial vessels and go towards the, when it is out of the tissue vessels, now it go towards the injurious agent. So this is a very good picture, and it shows the same thing. First of all, it was in the center, and slowly and gradually it goes toward the endothelial cells, and then it starts rolling pavement, and then sticking on the endothelial cell. This is called diabetes, which it allowing this neutrophil to go out, and finally it's moving towards the injurious agent. So this is how it goes: rolling, adhesion, diabetes, chemotaxis, phagocytosis, killing of the bacteria, and that's it. This is how normally WBC is doing, right? We have taken neutrophil as a prototype. It is for all these. The same story goes for lymphocyte, for macrophages, for eosinophil. Any cell which has to come out follow the same track. Okay. Now, chemotaxis is a propensity of the cell to be pushed to that area. Now, this is neutrophil and it is electron microscope picture, right? So, what happens that for chemotaxis, you need to have some attractant. Either it could be endogenous in the present or exogenous from outside the body, and usually they are bacterial products. Bacteria they attract, or endogenous by inflammatory mediators like uh, arachidonic acid metabolite, lipids, or cytokine, or complementary complements or component like C5a, or neutrophilic degradation itself cause attraction. Now, what happens then? Adhesion. So the cell get adhesion on the endothelial cells. For adhesion, you need either integrins, selectins, hemoglobin, superfamily, and glycoprotein. So how all these things happens? So you have to give me a little concentration, right? Here, what happens? The cell is here, and in the neutrophil, we have integrins and silyl Lewis X glycoprotein. In the neutrophil, we have two things. One is integrins. Number two, silyl Lewis X modified glycoprotein. In endothelial cells, we have P-selectin, E-selectin, means platelet selectins, endothelial selectin, plus we have ICAP, intercellular adhesion molecules. Now for P-selectin and E-selectin, the ligand is silyl Lewis. Clear? For silyl Lewis, it has to stick to P-selectin and E-selectin. For integrin, it will attach to ICAM. Clear? So integrin ligand is ICAM. For silyl, it is P-selectin, E-selectin. Now, how these things are activated? How these things are activated? So they have seen that, as the process of inflammation starts, this histamine and thrombin, this P-selectin and E-selectin usually are present inside the endothelial cell as Weber bodies. And as the histamine and thrombin comes out, these are chemical mediators. They pushes this Weber body on the surface as a P-selectin and E-selectin. Clear? Now they are activated now. On the other side, silyl Lewis X protein, they are also been activated, right? So this one comes down, and now it starts attaching to E-selectin and P-selectin, and this will help in rolling of the neutrophil. The function of E-selectin and P-selectin is not adhesion; it is rolling. And why you need rolling? Because you need this chemokine to come up and attach to the neutrophil. Why? Because the integrin here is of low affinity. It is closed. And if it is closed, it will not attach to the ICAM. You need to have opening of this integrin. And this opening is caused by these chemokine. They come up, attaches to the neutrophil. That's why you need a rolling. That while rolling, it come up, attached to the neutrophil. The integrin of low affinity will open and become high affinity. Clear? And if it is high affinity, it will join to the ICAM molecule. Now it is adhesive, attached. It does not allow neutrophil to move from it. Now comes PCAM. This PCAM has propensity to pull the neutrophil down outside the cortex. Clear? PCAM has propensity Now this basement membrane is very strong. So how this neutrophil cross? Neutrophil has collagenase enzyme. Neutrophil secretes collagenase enzyme, and it is so strong that it ruptures basement membrane. And as the basement membrane is ruptured, the neutrophils start coming. Clear? Anything, if it is not understood, let me know. Now, the histamine and thrombin, they are activating E-selectin, E-selectin. Now, this ICAM is how it is activated. It is activated by tumor necrosis factor and interleukin 1. Now, interleukin 1 and tumor necrosis factor acts on endothelial cells and activate ligand for integrin, which is ICAM. Now, ICAM is also activated. Integrate, which is of low affinity, become high affinity. Now they are stick together. They are not moving here and there. Then PCAM pulls the neutrophil out. Now it has to go towards the attractant, means macrophage, and the whole cascade starts. Clear? Now this is the chart which is showing that in endothelial cells you have E-selectin, E-selectin. The same thing which I have already discussed. So just look at this thing at your home, and it is very important because at the end you have some diseases because of the deficiency. It will not work, right? So you just remember that leukocyte has silyl and integrins. Endothelial cells they have selectins, right? So if there is deficiency, what will happen? Finally, the main function of the neutrophils are to kill the bacteria, right? To go there and killing of the bacteria. So how it kills? They have some receptor which is called toll-like receptor, which is present in every neutrophil or every white cells. So they recognizes the PAMP, which is pathogen associated molecular factors. So which recognizes a lipopolysaccharide. This is CD14. So how it acts? Just look at it. This is CD14. This is basically lipopolysaccharide, and this microorganism, this CD14 recognizes LPS, and it activates the neutrophil to start its function, right? Because you have to activate the whole cascade. So by joining this thing, cytokines start secreting, chemical mediators start secreting, and they are working on its own. Finally, we have also phagocytic receptors. Now, the neutrophils which are coming out, they have to kill the bacteria. How they kill the bacteria? This phagocytic receptor again recognizes the microorganism, and they engulf and take that microorganism in to be killed. Clear? Now, this WBC has a movement towards the microorganism, the phagocytose, and kill the bacteria. For killing the bacteria, you have two important pathways. One is oxygen dependent, which is called respiratory burst, and the other one is oxygen independent by lysosomal enzymes. 2-1, important one. Okay, so so they recognize the bacteria, phagocytic receptor. I have told you already. They engulf the bacteria, and finally they degrade the bacteria, kill it. This is how it looks like. We have phagocytic receptor, which I have already shown that picture, and this one. They recognize the bacteria. They pull the bacteria in as a phagosome. We have already lysosomal enzyme in the neutrophil. They form phagolysosome. They merge together, and they release their enzymes towards bacteria, and the bacteria is killed. This is oxygen independent killing of the bacteria, right? Now this is oxygen dependent. How it acts? We have phagocyte oxidase enzyme. This phagocyte oxidase enzyme convert this oxygen into superoxide. Now this superoxide divided into hydrogen peroxide and superoxide. Now we have another enzyme which is called myeloperoxidase. Now this myeloperoxidase pushes chlorine ion in, and this chlorine joined with hydrogen peroxidase to form hypochlorite. And this hypochlorite is the same bleach which you use for washing your clothes. They are so active in killing the bacteria, right? So by putting bleach, you are not only cleaning your clothes but also killing the bacteria, right? We have also hydroxyl ion with the help of this iron. They are also a strong killer of the bacteria, right? On the other side, we have this arginine, which secretes nitric oxide with the help of inducible nitrous oxide synthase enzyme. We have this enzyme with this phagocytic oxidase. We have this enzyme, myeloperoxidase enzyme, and we have inducible nitrous oxide. And this nitrous oxide pushes this inducible nitrous oxide synthase pushes nitrous oxide from the arginine into the cell, and this nitrous oxide join with superoxide and they form peroxynitrite. Peroxynitrite, write down, please write down. Peroxynitrite, they are also a strong killer of the bacteria. Is it clear now?
Yeah.
If it is not clear, I can repeat. Clear to everybody? Now what happens? Suppose if there is leukocyte adhesion deficiency type 1, means the integrins are not formed properly. Integrins, where it is present? In the neutrophils, right? In a low affinity state. So if there is a defect in biosynthesis of beta chain to form integrins, what will happen? There is no integrins. If there is no integrins, so there will be no adhesion, means the cell will not adhere with which cells? ICAM. Tightly adhere, number 1. Number 2, leukocyte adhesion defect type 2. In the absence of silyl Lewis X, the fucose containing ligand for E and P selectin result from defect in fucoside transferase enzyme. Here, fucoside transferase enzyme is not there. So silyl Lewis is not been produced. What will happen? There will be no rolling. And when there will be no rolling, what will happen? No chemokines. There will be no activation of, for example, if somebody has integrin in a low affinity, because there is no rolling, it is not coming down. So there will not attachment of the chemokine. And if it is not attached, what will happen? It will not stick to the endothelial cells. Third one is inherited defects of phagolysosome. The microbe has been engulfed by neutrophil. You have phagosome, you have lysosome, but phagolysosome are not joining together. In Higashi syndrome, you have phagosome, it is going in. You have lysosome, it is going in, but phagolysosomes are not formed. So you can see bacteria inside the neutrophil, but they are not being killed. Clear? The fourth one is inherited defect in gene encoding phagocyte oxidase. Let's go back. Now this phagocyte oxidase, they convert NADPH into NADP. By doing so, it is converting oxygen into superoxide. When superoxide is not formed, the whole oxygen dependent cascade will be finished. And this is 100 times more powerful than normal non-oxygen dependent. So the powerful action of this is destroyed. Clear? These patients are called chronic granulomatous disease. Remember, chronic granulomatous disease. These patients are always sick because they have neutrophils. When you check it, lot of neutrophils. Then why? Because they are not doing anything. There is a defect on this enzyme, and they are not forming superoxide. So all these cells, myeloperoxidase, inducible nitrous oxide, they are being blocked. And finally, lastly, inherited MPO deficiency in which this MPO is not formed. This is a problem. So when this MPO is not there, it is not pushing chlorine ion in. So they are not forming hypochlorite. So this also causes little bit damage to the cells. They are really very important. Please note this thing. Note this thing. Very important. Finally, in inflammation, either it resolves completely, nothing will happen, or this will be replaced by fibrosis, or finally go into chronic inflammation. So this is how it looks like. If normally what happens, acute inflammation within 1 or 2 resolves completely, nothing happens. Absolutely nothing. The organism enter your body, it has been destroyed, killed, and within 1 or 2 days you become absolutely all right. You don't even feel like having any disease. You feel like little lethargy, probably little temperature, but it is gone. Normally it happens like this. Sometimes because of the virulence of the bacteria is more, like staphylococcus or pseudomonas, pyogenic infection. It takes longer time. Probably it ends with also fibrosis. Or this acute inflammation directly go having fibrosis. Or sometimes what happens, acute inflammation after 4, 5, 6 days, it convert into chronic inflammation. All the neutrophils are gone, taken up by lymphocyte, plasma cell, macrophages, and this chronic inflammation heals in fibrosis. And sometimes it is not. There are some diseases like rheumatoid arthritis that this chronic inflammation prolongs and prolongs and prolongs and remain throughout the life. So this was all about inflammation here. Any question, please, you can ask. I can go back. If no question, we'll go for attendance. Be ready. Okay. Yes.
There's one student, he has an advance,
Is
he has an advance.
after this I'll let you know. The first thing. This is the first thing. All this comes first. So everything is actually good. Yeah. We'll discuss later. We have. In the next lecture, we will be discussing. Yes, it is important. It is important.
Can you please just send me this out? I was not connected to that.
Okay, those who are not able to make their attendance, we do it now. Welcome.
Sure, I have a question.
Yes, I'm here.
The LPS, when it's spiked, is it like an antigen?
It acts like a definitely because it is present in all the bacteria, right? LPS. So that acts as antigen to be, and they recognize. So we have receptor CD14. I think Dr. Gawan must have told you toll-like receptor. They recognize the bacteria and then the whole cascade. Yes. Yes.
Why do we have constriction like protein?
Let's have attendance first. Yes.
So do you want me?
Name.
Okay, so Yazan.
Yazan.
Yes.
One name.
Yazan.
Let's see. Where is Yazan?
Not sure, let's
No. This one, huh? Okay, done. Done. Nobody else. Nobody else. Yes. Now what? Yes.
Oh yeah, let him go. Okay, so my question was, why do we have constriction for like the first few seconds?
Actually, in the new book, I forgot to mention here. I mentioned in the girls' class. In a new book, they have taken out this thing because basically, when they were doing experiments in the animal, in the inflammatory process, they have seen a transient vasoconstriction for only 5 or 6 seconds, and suddenly it becomes dilated. So, in the new book, they say, why should 5 or 6 seconds? They're doing nothing, so they have taken this thing out. So, don't stress yourself why it is there is a transient vasoconstriction.
It could be to create a pressure difference.
Probably,
right?
yes, probably.
I'll stop everything.
Huh?
I'll just end it.
Yeah, close it.
Yeah, I'll log you off.